Hello everyone, my name is Dr. Khalil. I'm working as a consultant physician in medicine department, BMC Quetta. Today we are going to discuss about hypothyroidism. This is my friend Abdi Rashid. We have done MBBS together from BMC, and after that he joined JPMC and he is specialized as an orthopedic surgeon. Nowadays, he is working in Somalia as an orthopedic surgeon. He has institute as SOMAC. SOMAC is his own hospital. SOMAC, Somali Pakistan Specialty Hospital. He built there in Somalia and serving his own country patient. And this is picture of his Somek hospital. Today our learning objective of this presentation, at the end of this presentation you will be able to diagnose and manage a case of hypothyroidism at the bedside. What is the hypothyroidism? Let us learn the definition. Hypothyroidism, low functional activity of thyroid gland, is characterized by low circulating thyroid hormone, is called hypothyroidism. Hypothyroidism is the low functional activity of the thyroid gland, characterized by low circulating thyroid hormone T3 and T4. Production is called hypothyroidism. Hypothyroidism, it is often associated with subtle and non-specific sign and symptom. Any patient presented with the non-specific systemic manifestation, you always think for hypothyroidism. The prevalence 1 to 2%, female to male ratio is 10 and to 1. It is more common in female as compared to male. What are the various types of hypothyroidism and their characteristics? There are 3 clinical variants of hypothyroidism. First is the subclinical hypothyroidism. Second is primary hypothyroidism. Third is secondary hypothyroidism. There are 3 clinical variants of hypothyroidism. Subclinical hypothyroidism is characterized by high serum TSH and normal serum T4. Subclinical hypothyroidism is actually compensatory hypothyroidism, and it is commonly occur in women with advancing age. Subclinical hypothyroidism usually does not need any treatment. Second clinical variant is called primary hypothyroidism. Primary hypothyroidism is characterized by high serum TSH and low serum T4. If there is high serum TSH and low serum T4, it is called primary hypothyroidism. Primary hypothyroidism is the decompensated form of hypothyroidism, severe form of hypothyroidism. It needs treatment. And primary hypothyroidism is due to thyroid disease itself. The third clinical variant of hypothyroidism is called secondary hypothyroidism. Secondary hypothyroidism is characterized low serum TSH and low serum T4. Serum TSH and serum T4 both are low in case of secondary hypothyroidism. Secondary hypothyroidism due to pituitary or hypothalamic disorder. Now we are going to focus primary hypothyroidism. What are the causes of primary hypothyroidism? The most common cause of primary hypothyroidism is the chronic autoimmune thyroiditis, is also called Hashimoto-thyroiditis. Hashimoto-thyroiditis is the most common cause of hypothyroidism worldwide. The second, therapeutic thyroidectomy, removal of thyroid gland surgically, radioactive iodine therapy or neck radiation, severe iodine deficiency in LE region. There are certain drugs such as lithium, amiodarone, interferon, potassium iodide, antithyroid drug, they all can cause primary hypothyroidism. There may be congenital agenesis of the thyroid can result into primary hypothyroidism. What are the clinical manifestations of primary hypothyroidism? The physical examination, on journal physical examination, these are the some journal symptoms are most common. Patient may be present with the fatigue, with the tiredness, with the weight gain, and cold intolerance, deeper or hoarse voice, slow movement, presence of goiter, peach and cream complexion. These, the journal symptoms on physical examination are more common in case of primary hypothyroidism. This is image of peach and this is patient. This is look like peach complexion, peach and cream complexion. Remember that hypothyroidism can affect on every system of the body. Let us discuss briefly dermatological manifestation in case of primary hypothyroidism. Dermatological manifestation, patient may be present with the dry, coarse skin, loss of outer 1/3 of eyebrow, there may be puffy face and big eyelid, non-pitting edema over the arm and feet, and patient may be present with alopecia, hypothermia, xanthelasma. These are few dermatological manifestations in case of primary hypothyroidism. What are the musculoskeletal system manifestation, patient present with the arthralgia, myalgia, proximal muscle weakness, delay relaxation of ankle jerk, and patient may be presented with the carpal tunnel syndrome. What are the manifestation? Reproductive manifestation, reproductive system. Patient presented with the menorrhagia, infertility, galactorrhea, loss of libido, and miscarriage. And cardiovascular manifestation included bradycardia, diastolic hypertension, pericardial effusion, heart failure. CNS manifestation, patient presented with the fatigue, lethargy, headache and poor concentration, depression. Depression is one of differential diagnosis of hypothyroidism. Psychosis, coma, myxedema coma, and entrapment neuropathy such as carpal tunnel syndrome, and patient may be presented with deafness in case of severe primary hypothyroidism. Hematological manifestation, patient present with anemia. Anemia is mostly normochromic or macrocytic in type, but it may be microcytic in case of menorrhagia resulting in iron deficiency anemia. Anemia in case of primary hypothyroidism, it may be normochromic, may be macrocytic, or it may be microcytic in case of iron deficiency anemia due to menorrhagia. GI manifestation include anorexia, loss of appetite, constipation, adynamic alias, megacolon. Pulmonary manifestation may include pleural effusion, cor pulmonale, hypercapnia, and bacterial pneumonia. Bacterial pneumonia is most common in case of primary hypothyroidism. Patient with primary hypothyroidism presented with the fever, cough, short of breath, chest pain, you must rule out bacterial pneumonia because bacterial pneumonia is most common in case of primary hypothyroidism. What are the investigation? How would you like, how will you investigate a case of hypothyroidism? For the investigation, there are investigation divided into three categories. First, you have to diagnose the disease, diagnose the hypothyroidism, then ascertain its etiology and complication. First investigation to determine the diagnosis of hypothyroidism. For diagnosis of hypothyroidism, we would like to do serum TSH and pre-T4. Serum TSH will be high and usually greater than 20 milliunit per liter in case of primary hypothyroidism, while pre-T4 will be low. Serum TSH will be high, usually greater than 20, and T4 will be low. Is the diagnostic investigation for primary hypothyroidism. While in case of secondary hypothyroidism, the serum TSH and pre-T4 both become in lower limit. Both become low. But you also remember sick euthyroid syndrome. sick euthyroid syndrome that is characterized by low pre-T4 and are normal or low TSH level simulating secondary hypothyroidism. When you are going to diagnose a case of secondary hypothyroidism, you must think about sick euthyroid syndrome. Because the sick euthyroid syndrome and secondary hypothyroidism biochemically look like same. In secondary hypothyroidism, there will be the low T4 and low TSH. In sick euthyroid syndrome, there will be also low T4 and low TSH. Because sick euthyroid syndrome, it occurs with non-thyroidal illness. Maybe in case of severe sepsis, in case of severe disorder, severe illness. So, sick euthyroid syndrome, it is actually a protective mechanism of the body. You must be beware about sick euthyroid syndrome when you are going to diagnose a case of secondary hypothyroidism. One thing is that. Other thing is that, yes, we know that secondary hypothyroidism is due to pituitary and hypothalamic disorder. So, we also search out other hormone deficiency of anterior pituitary gland. To confirm our diagnosis, we also search out the other hormonal deficiency of anterior pituitary gland. Investigation to find out, to ascertain its etiology and complication. First, to confirm the diagnosis, you have to do the serum TSH and serum pre-T4. Second, to find out its etiology and complication. For the etiology, we have to do the TPO, serum antithyroid peroxidase antibodies. As we know, the hematothyroditis is the most common cause of primary hypothyroidism worldwide. And this serum antithyroid peroxidase antibody TPO rise in autoimmune thyroid disease hematothyroditis. Suppose the patient presented with the subclinical hypothyroidism. In case of subclinical hypothyroidism, the TSH will not be greater than 20 milliunit per liter. And you are thinking subclinical hypothyroidism, and you are going to do the thyroid peroxidase antibodies. If the thyroid peroxidase antibodies is present in subclinical hypothyroidism, it means increase the risk of developing overt hypothyroidism in future. Those patients with subclinical hypothyroidism having raised TPO, they have increased risk of frank hypothyroidism in future. For etiology of primary hypothyroidism, we must do antithyroid peroxidase antibodies in case of hematothyroditis. For other etiology, you are also going to take the history, such as surgery and radiation to the neck, and you also to take the history about the certain drug, such as lithium, imidrone, interferon, antithyroid drug. For complication, We will do the CBC. CBC in case of primary hypothyroidism may be present, may be show normocytic or macrocytic anemia, and maybe CBC shows microcytic in case of menorrhagia. Is seen in women with AV fluid. Serum electrolyte shows hyponatremia due to excess ADH secretion in case of primary hypothyroidism. Elevated serum LDL cholesterol and hypertriglyceridemia, common in case of primary hypothyroidism. You have to do the ECG. ECG may show sinus bradycardia, low voltage complexes, and screening ECG may need for ischemic heart disease before initiation of thyroxine, and especially in elderly patient. Especially in elderly patient, you are going to prescribe thyroxine, you have to do ECG before starting thyroxine to rule out the ischemic heart disease. Because thyroxine can increase the metabolism, can increase the angina, can worsen the ischemic heart disease. So that the thyroxine, when you are going to start an elderly patient, always start from low dose. X-ray, chest X-ray, to look for cardiomegaly and pericardial effusion. These are the some certain investigation to ascertain the complication of hypothyroidism. How would you like to treat a case of primary hypothyroidism? Replacement therapy with levothyroxine is recommended for life. Lifelong. You have to prescribe thyroxine to your patient lifelong. Definitive treatment of primary hypothyroidism is the thyroxine lifelong replacement. The aim of therapy is to restore euthyroidism, bringing back T4 and TSH within the normal range. The recommended dosage usually depend on the severity of the disease, age, and presence of comorbidity. If patient presented in the elderly age, you have to start with low dose. If the patient is the young, fit individual, the recommended dose 1.7 microgram per kg per day. Dose of thyroxine may be recommended. This is all about primary hypothyroidism. Is it clear? Whenever the art of medicine is love, there is also a love of humanity. Thank you.